Welcome to The Explainer. Today we're diving deep into one of the most complex, high-stakes environments in the entire human body, the pelvis. For a rectal surgeon, this isn't just anatomy class. No, this is a critical mission where literally every single millimeter matters.
And that brings us right to the heart of the matter, to this central puzzle. How is it possible that the single most important landmark for a surgeon to get their bearings, the keystone of the whole operation, is also the most dangerous and difficult spot to work in? Let's dig in.
Okay, so let's unpack this paradox. On one side, you have the sacral promontory. Think of it as the surgeon's North Star. It's where you start, it's how you know where you are. But it's also a fusion zone. All those nice, clean tissue planes that usually give you a safe path to follow, they're all stuck together here. There's no bloodless layer, which puts crucial nerves and veins at serious risk and means you have to dissect with absolute precision very sharply. So, to navigate a place like that, you need a map key. And in the pelvis, that key is understanding the fascial layers. These are the sheets of connective tissue that basically wrap, separate, and define everything in the surgical field. Get these right, and you're on your way.
So let's start from the inside and work our way out. First up is the fascia propria of the rectum. The easiest way to think of this is as the surgical capsule. It's this thin, almost shiny layer that hugs the mesorectum. That's the fatty tissue and lymph nodes you're trying to remove in a cancer operation. Your entire goal is to stay just on the outside of this layer.
And right outside that capsule, that's where you find the areola plane, better known as the holy plane. Now this is the surgeon's highway. It's a relatively bloodless path made of loose tissue. Finding this plane and, more importantly, staying in it, that is the absolute bedrock of modern rectal surgery. Now, the outer wall of that highway is the parietal pelvic fascia. You can think of this as the wallpaper of the pelvis, lining the bony walls. And just on the other side of that wallpaper are all the things you absolutely positively cannot injure. Major nerves for bladder and sexual function, and the infamous presacral pains. And what holds this whole complex system together? Well, that's the endopelvic fascia. This is the architectural backbone of the whole area. It's a web of connective tissue that thickens in certain spots to form the ligaments that hold the rectum and other organs in place. So this little cheat table really brings it all together. You see the fascia propria and mesorectum? Those are your targets. They define that holy plane we talked about. But look at the endopelvic fascia. It's structural support. It is not a dissection plane. The memory pearls say it all. You're working in the plane, not on the architecture. All right, so we've got our map key. We understand the layers. Let's put it into practice. We start at the entry point, the first and most critical part of the operation, the posterior dissection. Getting into the holy plane isn't a guess. It's a very specific four-step move. First, you find that sacral promontory, our North Star. Second, you find a thickened band of tissue right below it called Waldeyer's fascia. Third, and this part is absolutely crucial, you have to divide that fascia sharply with scissors or energy. Trying to pull or push away through is a recipe for disaster. Only after you make that clean cut can you slip into the safe avascular holy plane. And the stakes here are just incredibly high, which is where this bit of surgical wisdom comes from. This is talking about the presacral venous plexus, which is this delicate web of veins. One wrong move, and you can cause bleeding that is catastrophic and notoriously difficult to control. Okay, so we've made it past the tricky posterior entry, but the pelvis isn't a flat road, it's a 3D puzzle. The journey has to continue around the sides and to the front, so let's go ahead and explore the danger zones in the lateral and anterior planes. As we move around to the front of the rectum, the space just gets unbelievably tight, especially the deeper you go into the pelvis. All the important structures are packed right on top of each other. Your margin for error just shrinks to practically nothing. And here's where a key anatomical difference creates a real challenge. You can see the working distance from where you start your dissection down to the pelvic floor is way smaller in females. We're talking sometimes just 2 centimeters. That demands an even higher level of precision. So in this incredibly tight anterior space, there's a critical area that surgeons have mapped out. It's a no-fly zone designed to protect vital functions. It is known as the Holy Triangle, and knowing its boundaries is everything. You've got the ureter on the side, the vas deferens or uterine artery in the front, and the hypogastric nerve in the back. The rule is simple. You dissect around this triangle. You never, ever go through it. Which leads us to this powerful surgical saying: And of course, it applies to women too. Protecting the structures inside and around this triangle is the absolute key to making sure a patient maintains their long-term urinary and sexual function after the surgery is over. So with all of this crazy, intricate detail, how does a surgeon possibly keep it all straight in the middle of an operation? Well, they don't just memorize a list of facts. They build a living, dynamic mental map of the entire territory.
And we're not talking about some flat two-dimensional drawing here. The framework a modern surgeon uses is actually a really sophisticated three-level mental architecture. It's what turns all this anatomical knowledge into split-second surgical decisions.
So let's break that down. Level 1 is the geography, just visualizing the pelvis as a box with a front, a back, and sides. Level 2 is the compass, constantly checking which fascial plane you are in. And level 3, that's the functional overlay. It's like a nerve map that highlights all the zones you have to protect to preserve quality of life.
And what's so important to get here is that this mind map is not static. It's not a dusty old chart. It is constantly being updated. High-resolution MRIs before surgery let surgeons scout the area and plan ahead, while things like robotic surgery give them the magnified vision and dexterity to navigate those challenges like never before.
And this last quote, it just perfectly sums up the mental shift a surgeon has to make during the operation. Above that sacral promontory, you're a collector. You're efficiently gathering up the specimen for the cancer. But the moment you drop below it, into that deep, narrow space, you have to become a sculptor, carefully and delicately carving around these priceless nerves and tissues.
Which really leaves us with a fascinating question to end this explainer. As this anatomical and functional map gets more and more detailed, thanks to better imaging and sharper tools, what's next? What new territories of improved patient function, faster recovery, and a better quality of life will surgeons be able to explore and conquer?